Okay, so let us discuss about the first series of cranial nerves. So I will just be running through all the cranial nerves, what's basic about them, and then in our second series, we'll talk about other cranial nerves in detail, like cranial nerve number 7, number 5. All right. Okay, perfect. So now we would like to, for now, look at the objectives of this discussion. So within this discussion, we'll be looking at the just for the beginning, just discuss the anatomical subregions in the head and neck. So head and neck is a region. We divide it as well into subregions. So being one of those regions packed with lots and lots of viscera and muscles. And then outline the cranial nerves and their function. And for another topic, another day, we'll also discuss the anatomy of the scalp and outline the clinical correlates, and then discuss the lymph drainage of the head and neck. Okay, but for this tutorial, we'll discuss the anatomical subregions in the head and neck, then outline the cranial nerves and their functions. So for now, I would like to just run through the subregions. So we have the orbit, we have the nasal and the paranasals, we have the oral and the submandibular region, we have the ear, we have the temporal, the infratemporal, the pterygopalatine fossa, we have the larynx, we have the pharynx, and we have the neck. So in the neck, we'll look at osteology, we'll look at the compartments in the neck, we'll look at the glands in the neck, so top of the thyroid and the parathyroid glands, we'll look at the vessels in the neck, and also look at the nerves, right? So for this discussion, allow me to talk about the cranial nerves. So from the name cranial, that means top, right? Cranial nerves, right? So these are basically nerves rooting straight from the brain. So our nerves, basically, we know that a nerve that's like a band of axons outside of the central nervous system, and they root either from the brain itself, the brain stem, or the spinal cord. So whatever is rooting from the spinal cord is called a spinal nerve, but these ones are rooting from the brain stem and also from the brain itself. So these are called cranial nerves. So there are 24 in number, but 24 this number is actually coming from the 12 pairs. So we don't have 12 cranial nerves, we have 12 pairs of cranial nerves. So we have 12 pairs of cranial nerves, that makes up 24 nerves. So 12 one side, 12 the other side. So they root from the brain and also from the brain stem, right? So they root from the brain and also from the brain stem. So generally, our central nervous system, as we know, is divided into a brain, right? And we have a part that is called a brain stem, right? And then from there, we have our tail-like spinal cord that extends downwards. So I'm saying anything that's coming from the brain stem and also the brain, those collection of axons are the cranial nerves, and they're actually 24 in number, being 24 pairs, being 12 pairs. Right, so they form the main nerve supply of the head and the neck, right, obviously. And then lesions of the nerves commonly present with clinical features in the head and neck, obviously. Right, so the numbering are pairs from 1 to 12. So the first one is called olfactory nerve, right? The second one is called the optic nerve. The third one is called the oculomotor nerve, right? So our 3 O's, right? And then the fourth one is the trochlea nerve. And the fifth one is the trigeminal. So our 2 T's, right? So here we have our 2 T's at this point, and here we have our 3 O's, right? Starting there, right? And then we have our 6th abducens nerve, and here we have the facial nerve, and here we have the vestibulo cochlear nerve, and number 9 we have the glossopharyngeal nerve, and number 10 we have the vagus nerve. We know this one from thorax and also abdomen. And then number 11 with the accessory, and number 12 with the hypoglossal nerve, right? So you can go on YouTube and then check the mnemonics, a number, so many mnemonics that are used for you to remember all the 12. But I bet within 2 weeks, you'll be so familiar with all these numbers. So practice that: olfactory, optic, oculomotor, trochlea, trigeminal, abducens, facial, vestibulo, cochlear, glossopharyngeal, vagus, accessory, then hypoglossal. So looking at our cranial nerve number 1, the first one is the olfactory nerve. So this is basically coming from the telencephalon. So when I say telencephalon, I'm talking about the hemispheres, right, of the brain. So it's rooting straight from the brain, and then it goes to the roof of the nasal cavity. So within the nasal cavity, it goes to the roof of the nasal cavity, because on that roof, we have something that's called the olfactory epithelium, that is got receptors to sense smells or take smell, right? Or the molecules, so it changes that chemical energy into the impulsive energy that goes to the brain, and that is going through the olfactory nerve. So remember, it's going to the olfactory epithelium and the roof of the nasal cavity. So that's the only cranial nerve that roots from the telencephalon, right? So the only cranial nerve that roots from the hemispheres. Okay, so when I talk about the hemispheres, I'm talking about these structures. Let me try to just illustration. So that hemisphere, right? So it's rooting straight from that hemisphere, right? So straight from there goes onto the roof of the nasal cavity. So how does it get there? So it enters the nasal cavity through the cribriform plate, right? So with a cribriform plate of the ethmoid bone, right? So when we talked about osteology, I showed you what's the cribriform plate and the body of the ethmoid bone and the sinuses within the ethmoid bone. So here we're talking about the roof of the nasal cavity that is formed by this plate, right, of the ethmoid bone. So it's called the cribriform plate, and there we see perforations on that cribriform plate. So the olfactory nerves actually be passing through there, right? And then actually carries olfactory impulses to the central nervous system, yes, and then loss lesion of this nerve then leads to loss of smells or nose smear, right? So nose smear, irritation of that nerve will then give funny smells, right? So that is just that what you need to know concerning the olfactory nerve, right? So it enters through the anterior cranial fossa, right? Enters into the nasal cavity. Or to say it exits from the nasal cavity because information is going to the brain, really. So cranial nerve number 2 is the optic. So remember that you have one nose and then you have 2 eyes. So optic, that has to do with the eyes. So optic nerve. Yes, from the diencephalon. So it's also coming from the forebrain, but no longer from the telencephalon. This one is now coming from the diencephalon, right? So it's coming from the diencephalon and it's coming from the thalamus, really, right? Thalamus and the part of the thalamus that they call the laryngogenic limb body. But for now, just know it's coming from the thalamus, the diencephalon to the eye, obviously, right? So that's the only cranial nerve that's also coming as well from the diencephalon, and then enters the orbit through the optic canal. So enters the orbit through the optic canal. And remember the optic canal from our osteology discussion, right? Being an opening in the lesser wing of the sphenoid bone. So it is a direct, so get that, it is a direct extension of the forebrain. So being an extension of the brain tissue, being an extension of the central nervous system, the word nerve is really improper. Okay, the word nerve is really improper. That's why we see the optic nerve has the dural coverings, and the dural coverings are the covering that we see covering only the central nervous system. So they also have the dural coverings. We'll talk about the dural coverings as the introduction to neuroanatomy. So formed from axons of ganglion cells in the retina. So it's formed from axons of ganglion cells within the retina. So it carries visual impulses to the central nervous system, to the occipital lobe. Yes, to our occipital lobe. Correct. So lesion leads to blindness, anopia, and we have different types of blindnesses depending on the level of the lesion of that nerve, right, on its pathway from the eye until we get to the occipital lobe within that central nervous system, right? So we describe the different types of blindness in neuroanatomy, right? So that's the optic nerve enters via the optic canal. So cranial nerve number 3 is the oculomotor nerve. Cranial nerve number 3 is the oculomotor nerve. So from the ventral midbrain to the orbit. So this one is now coming from the midbrain. So we're now on our brain stem. So our brain stem, remember I said we have our forebrain, right? Where we have cranial nerve number 1 and cranial nerve number 2, right? Rooting from. Then we have something that's called a brain stem. So a brain stem is made up of the midbrain, short but big. And then we have what we call the pons that looks like a pregnant woman, right? So the pons like that, right? And then we have our medulla oblongata, right? And from the medulla, then we have the spinal cord going downwards. So this is the brain stem, right? So from this brain stem behind there, that's where we have our cerebellum. So there we have our cerebellum. For balance, my funny drawing our cerebellum, but really we don't talk about the cerebellum, we talk about the cranial nerves. We'll talk about it in neuro anatomy, right? So here I'm saying that the third cranial nerve is now coming from here now, right? The midbrain. So it's coming from the front. So when coming from the front, we call that the ventral surface. So it's coming from the front. So that is called the oculomotor nerve. So it's coming from the ventral midbrain. So it carries somatic motor fibers. So the ones that you can actually control, somatic motor fibers. And where are these going? They're going to supply the extraocular muscles. So muscles outside the eye, muscles that move the eye, right? So when you want to look to the left, look to the right, when you think about it, you control those muscles to actually then control your gaze, right? So how does it enter then into the orbit? So it enters the orbit through the superior orbital fissure. We'll also discuss about the superior orbital fissure in our discussion in osteology, right? So it supplies the extraocular muscles, except these two muscles, the lateral rectus muscle. So for now, just remember, it doesn't supply a muscle that is an ara and an L, an L and R, sorry. It doesn't supply a muscle that is an L and R, right? So the lateral rectus, it doesn't supply the right lateral, and also the superior oblique. So in SO, it doesn't supply SO, it doesn't supply LR. So it supplies all the other extraocular muscles except the lateral rectus and the superior oblique. And we'll discuss about the extraocular muscles when we talk about the orbit. But for now, just know it supplies the extraocular muscles except the lateral rectus and the superior oblique, right? So it supplies the inferior oblique, it supplies the medial rectus, supplies the superior rectus, supplies the inferior rectus. So lesion, right, of this nerve leads to a downwards and an outward gaze. So we call that a down and out look, right? So if this is the nose, right, that's the nose, your eye will be looking down and out, right? So like you're looking to at your hands. So if you stand in the anatomical position and then you look at your palm, right? So that's called a down and out, right? And we also lose parasympathetic innervation to the eye because the oculomotor has some fibers as well that are carrying parasympathetic as well from some centers within the midbrain, right? But we'll talk in detail about that in neuroanatomy, right? So cranial nerve number 4, the fourth one is the trochlea, right? So the word trochlea means pulley. So you know our pulleys, like in mechanics. So you have a rope going there, come there, that's a pulley. So that's a trochlea. So the trochlea nerve. So we want to see why it's called the trochlea nerve. So it's from the dorsum. So now this one is coming from the back of the midbrain. So it's coming from the back there, right? And then it winds and then it starts moving forward. right? And by that fact, it's the most slender, so it is the fewest axons, right? Cranial nerve, so it's the most slender cranial nerve with the longest intracranial. So I want you to get this word, intracranial. So within the cranial, the cranium, this is the nerve that is the longest course. Why? Because it's coming from the back and it's to go forward. So it's winding around the midbrain. So it is the longest intracranial course, right? And it's the only nerve that exits from the dorsum of our brain stem. So all the other cranial nerves are coming from the front. All the other cranial nerves we talk about are also coming from the front, but it's the only one that comes from the dorsum. That makes this unique. So it enters the orbit through the superior orbital fissure, the one that has been used by the oculomotor. So it provides somatic, the one that you can control, motor innervation to the superior oblique muscle, right? So that SO muscle is not being supplied by the trochlear nerve. So the superior oblique muscle, part of its attachments and movements in the orbit is a small part of bone that is found on the lacrimal bone that is called a trochlea. So it hooks on that trochlea, comes back and then inserts on the globe of the eye, right? So because of that fact that this muscle hooks on that trochlea, hooks on that pulley, we actually then call the nerve that supplies a trochlear nerve. So always remember that, right? Then lesion of this one leads to a down and inward gaze. So you understand more of this when you talk about the movements that are created by the extraocular muscle. So remember, this one is down and inwards, right? Down and inwards. Now, cranial nerve number 5 is the trigeminal. So the word tri, that means 3, geminal, germinating, 3 roots, trigeminal nerve. So this is coming from the ventral pons. So you come here, this is our pons, so it comes from there, just ventral, and then goes down, right? So the trigeminal nerve, right? It's one bundle coming off, though it is a small motor root. But for now, we'll talk about that neuroanatomy. But for now, the trigeminal nerve is coming from the ventral part of the pons, and then goes to the skin, to the orbit, to the skull, to the nasal, to the oral cavity, to the anterior belly of the digastric supplying motor, to the tensor tympani in the ear, to the 4 muscles of mastication, right? So this compound nerve divides into 3 branches within the cranium. So that's called tri. 3 branches within the cranium. So we have V1, so V is for 5, cranial nerve number 5, so we have 5, 1, 5, 2, 5, 3. So the V1 is the ophthalmic division. So by the word ophthalmic, it's going towards the eyes, right? And it's purely sensory. It's purely sensory and gets into the orbit through the superior orbital fissure. Then V2 is our maxillary division. So it's going around the region of the maxilla and it's purely sensory. And then it enters or exits the cranium through the foramen rotundum, right? And then V3 is our mandibular division. So goes around the region of the mandible, being the largest, and also it's mixed. So it's sensory plus motor. So it's also sensory plus motor and then exits to the foramen ovale. So superior orbital fissure, foramen rotundum, foramen ovale. So V3 really, when you talk about embryology, so when you talk about embryology, that's the nerve of the first pharyngeal arc. So in embryology, talk about the pharyngeal arches, first, second, third, fourth, and sixth. This is now the nerve of the first pharyngeal arc. So just get that, right? So lesion of this nerve will lead to sensory deficits around the region of the eyes, around the region of the maxilla, around the region of the mandible, right? And also have paralysis of the 4 muscles of mastication. So now, because this one is the one that is motor, that's the one that will supply these muscles that we're actually seeing here. All right. Cranial nerve number 6, right? So we are halfway. Cranial nerve number 6 is abducens. So I want you to get the word abduction from the abducens, abduction. So abducens nerve. So I'll let you know why we call it the abducens nerve. So it's from the pontomedullary junction. So ponto, that is a junction between the pons and the medulla, right? So go back to our picture. So these pons, that's the medulla. So it's coming from the pontomedullary junction. So from there, right? So coming from the pontomedullary junction, and it goes to the orbit, and then to supply that remaining LR, right? The lateral rectus, right? So it's somatic motor to the lateral rectus, and the lateral rectus, if you have our eye at this point, and here we have the nose, medial, right? Our Pinocchio nose, nose here, nose there, right? It turns the eye exactly horizontally out. So your eye will be looking out, right? Like that. So you're looking out, you're looking at your friend by your side, you're using the lateral rectus on that eye, on that side, right? So the lateral rectus is doing abduction of this eye, right? So it's doing abduction of this eye, right? So because it's doing abduction, the nerve that will then supply the lateral rectus for lateral, that's outside, right? Lateral rectus, rectus means straight. So it's straight lateral, which is also abduction. So the nerve is then called the abducens nerve. So exists the cranial through the superior orbital fissure, and then it's related inferolateral, right? It is one relation which is related to the internal carotid artery, right? So it's actually inferolateral to the internal carotid artery. So it's actually inferolateral, just pardon my writing there, it's inferolateral to the internal carotid artery within something like called the cavernous sinus. So basically a bag of blood, venous blood that we call the cavernous sinus. So it's also there as well with the internal carotid artery. So it's inferolateral to the artery. So paralysis of this will obviously lead to your eye looking medial, and that's called medial gaze. So we have medial gaze. So your eye is just, when you try to look straight, it will run medial. So for the medial strabismus, right? Okay, so kind of number 7, the famous one, the facial nerve. So facial nerve. So it's from the pontomedullary junction as well, right? So now we've seen 2 nerves already coming from the pontomedullary junction, which is the abducens nerve and the facial nerve, right? To the ear, to the muscles of the facial expression. So it supplies muscles of facial expression. It supplies also some muscles in the ear. So it goes to the ear, muscles of facial expression. It goes to the stapedius. So the stapedius, that's actually that muscle within the ear, because its course, it moves within the ear. So we'll talk about in detail about it in our second series. And it also goes to supply the posterior belly of the digastric muscle, posterior belly of the digastric muscle. Then digastric muscle, we'll talk about it. Talk about the muscle. When we talk about the muscles, it goes to supply the stylohyoid muscle. It's also supplied the tongue mucosa, right? So the mucosa of the tongue, right? It takes taste from the tongue and then supplies our glands, the lacrimal gland for crying, the submandibular gland for salivating, the sublingual gland for salivating, and also, like I said, taste from the anterior 2/3 of the tongue. So always remember that the anterior 2/3 of your tongue, the taste is then carried by that facial nerve. So how does it exit the cranium? So it exits cranium through the internal acoustic meatus, and then superior to cranial nerve number 8. So they are related. They are all within that internal acoustic meatus, but the cranial nerve number 7 will be above. So you can call that 7 up. So remember the drink, 7 up. So cranial nerve number 7 has to be up. Right, so lesion leads to several symptoms now, because it does loads and loads of functions, right? For example, Bell's palsy, paralysis of the muscles of the face, hyperacusis, you'll be hearing sounds so loud than normal. Then you have a dry mouth and you have a dry cornea, you cannot cry, right? So you have lacerations of the cornea that may lead actually to perforations of the cornea, and then you have inflammation of the cornea going on and on like that. So it divides the parotid gland, so it moves within the parotid gland, going onto the face. So by doing that, it will be dividing the parotid gland into a superficial and a deep part, right? And within that parotid gland, that's where the facial nerve actually then terminates, dies off into its common branches or within the parotid gland, but does not supply. So always remember, it does not supply this gland. So see all the glands that I've talked here about here, we did not see something called the parotid gland. So it's just within the gland, but not supplying. And it's the nerve of the second embryological pharyngeal arc. Second pharyngeal arc. Always remember that. Then cranial nerve number 8 is called the vestibulo-cochlear nerve. So it's coming from the vestibule, it's coming from the cochlea, and these structures are found in the inner ear, right? So it's from the pontomedullary junctions. We've seen the third, another third cranial nerve, right? Not third cranial nerve, but the third one, right? So counting number 1, abducens, number 2, facial, number 3, vestibulocochlear, right? It's also coming from the pontomedullary junction to the inner ear. And how does it do that? Enters through the internal acoustic meatus. So pardon my handwriting there. Internal acoustic meatus. Or pardon my spellings, really. So for the functions really are for hearing. So the branch that is coming from the cochlea. So we have a cochlear part, right? And a vestibular part, and they combined from the vestibulocochlear nerve. So the vestibular part is carrying balance impulses, right? So for you to balance your head, right? And then hearing is coming from the cochlea. So cochlea is a structure within the inner ear that is used for hearing, and we'll talk about it when we talk about the anatomy of the ear. So lesions will lead to hearing loss, right? And also loss of balance. So you cannot coordinate your movements because you don't have balance, and that is called ataxia. And you have a tendency to just fall, right? And that is called an ataxic gait. You just can't stand properly, right? So loss of coordination movements, right? So it's related to cranial nerve number 7, remember, facial nerve up, 7 up, and also the labyrinthine artery within that internal acoustic meatus, related in the labyrinthine artery and cranial nerve number 7. Right, then glossopharyngeal nerve number 9. So from the nerve gloss, that has to do with the tongue, pharynx, with that inlet to go to the esophagus, so glossopharyngeal. So it arises now from the medulla oblongata. So this one doesn't arise from that pontomedullary junction. Now we're on the medulla oblongata between oris and inferior cerebellar peduncle. We talk much about this in neuroanatomy, not much of importance. So you now just know it coming from the medulla oblongata. So exits cranial through the jugular foramen, supplies the pharynx, being sensory, supplies taste now the posterior third. Remember the anterior third of the tongue was the facial. Now to the posterior third of the tongue is now the glossopharyngeal. And it's motor to one muscle, the stylopharyngeus, and is the nerve of the third pharyngeal arc in embryology. Then paralysis will lead to the loss of what we call the gag reflex, so gag reflexia. So to explain the gag reflex, it's when you touch the posterior part of the oral cavity or you touch the pharynx, you cough, right? You cough, you have that feeling to vomit. That's called the gag reflex, gagging, right? So because now the pharynx takes sensory information from that pharynx, right? It takes sensory from that part, and then it takes that sensory, goes with the sensory to the central nervous system, right? Our central nervous system. And there's a nerve that will come and then supply the muscles that will then be contracting. So because this is going to the central nervous system, that's afferent. This is coming from the central nervous system. This is efferent, supplying the muscles. So the afferent limb of the gag reflex is then formed by the glossopharyngeal. Then the efferent is formed by the vagus nerve, which we'll talk about, cranial nerve number 10. So we'll lose that reflex. So you cut one part of the limb, then you fail to have that gag reflex. So paralysis as well of the stylopharyngeus muscle and loss of taste from the posterior third of the tongue, right? So when you want to test the integrity of the glossopharyngeal nerve, you do 2 tests. Test number 1, you do the gag reflex test. Test number 2, you then also put salt on the posterior third of the tongue, right, to just confirm. Vagus nerve. So it's from the medulla as well, right, between olive and inferior cerebellar peduncle. But for now, no, it's coming from medulla oblongata, right? So it exits the cranium through the jugular foramen as well, and has the longest extracranial course. So remember, longest intracranial course was our trochlea. Now this one is the longest extracranial course, and we see it going as far as the distal midgut, the ending of the midgut within the abdomen. So supplies motor to muscles of the pharynx, larynx, taste from the epiglottis, touch around the auricle, the ear, right? And also touch from the larynx, a small part of the larynx as well. And also it has parasympathetic innervation to the GI system and also the respiratory system, right? You have been familiar with this nerve in the thorax and also abdomen. So lesions result in various clinical signs. So loss of parasympathetic in many areas of the body, right? And we actually lose the gag reflex as well, because this one is forming the efferent limb now that is coming from the central nervous system to supply the muscles that will then lead to you coughing. So we have a change in voice, right? Change in voice and change in your respiration, because it's also supplying the larynx that also does force production. So we have a change in your voice because the larynx is then the pathway as well for respiration, because the parasympathetic to the lungs is the vagus nerve. So also changes that. It also changes the heart activity, changes the GI mortality, and also changes the integrity of the bronchus, the airways. So we have bronchodilation in that way. Okay, so in that way now we'll actually have bronchodilation, because that's the sympathetic effect that will now be left. Now this is now the nerve of the fourth and the sixth pharyngeal arc. Nerve of the fourth and the sixth pharyngeal arc. So testing is all the integrity of the vagus nerve. You do the gag test, right? And also do other tests. I mean, we have different areas that it also supplies. Okay, so normally you just do the gag test, right? Okay, so cranial nerve number 11, accessory nerve. So this is also coming from not the pontomedullary junction. That's a mistake there. It's coming from the medulla, right? Not the pontomedullary junction. It's coming from the medulla. It's coming from the medulla, and also it has a contribution from first 5 cervical nerves, right? First 5 cervical nerves. So the 5 cervical roots, because they're in the neck, they go up through the foramen magnum, get into the cranium. Those are called the spinal roots of the accessory nerve. So get into the cranium, they join with the cranial root. The cranial root is the one that is coming out from the medulla, right? And they join to form the final or the definitive accessory nerve. Then that accessory nerve would then exit the cranium through the jugular foramen. So always remember, the spinal roots get into the cranium through the foramen magnum, join with the cranial root, and then form the final bundle, the accessory nerve. So this nerve will then supply the muscles of the pharynx, and also the sternocleidomastoid muscle and the trapezius muscle, muscles of the neck, these 2 muscles of the neck, right? The cranial root of the accessory nerve, that one that branches from the medulla, is truly part of the vagus nerve, because once it exits out of the cranium, it joins the vagus nerve to go and supply muscles of the pharynx. So it can also be called a vagal accessory nerve, right? And then the spinal root C1 to C5 will then just supply the sternocleidomastoid muscle and the trapezius. So it's purely motor, like cranial nerve number 6 was purely motor, cranial nerve number 4 was purely motor, and also number 12 that we'll talk about, right? So these are purely motor, 11, 6, 4, and 12. Then the hypoglossal nerve is coming from the medulla as well, right? Between pyramids and oleus. We'll talk about in detail about that in neuroanatomy. So exits the cranial through the hypoglossal canal. Then supplies pure motor nerve supply, no taste, nothing, just pure motor to the muscles of the tongue, except one muscle of the tongue that is called the palatoglossus. So glossus, tongue, remember hypoglossal. So glossus, tongue, it supplies the muscles of the tongue, except the palatoglossans, because it's the muscle of the palate, of the smooth palate. Right. Then lesion of this nerve results in the tongue deviating towards the affected side when the tongue is protruded. So when you ask the patient to protrude the tongue, bring the tongue out, if the nerve on the right side, if the right hypoglossal nerve has a lesion or is actually been injured, the tongue will point towards the side of the lesion. So always remember that. Always remember that the tongue will protrude and then turn towards the affected side. Why? Because that is the unbalanced push of the muscles that are called the genioglossus that push the tongue forward. So if one is overpowering, it will push towards the weak one, right? So that is testing the integrity of the hypoglossal nerve. So that brings us to the end, the magumo of our cranial nerves, or tsinga, right? So that's the end, and thank you so much for paying attention to that. So always revise and revise again.